Welcome back to Physio Discussed, the podcast where clinical insight meets real-world impact. In this episode, we're tackling a topic that is often misunderstood, under-discussed and deeply impactful. That is pelvic pain. And we've brought two absolute legends in to guide us through it. Sandy Hilton, a powerhouse in pelvic health physiotherapy. Bill Taylor, a clinical researcher and educator with decades of experience bridging the gap between musculoskeletal and pelvic health. Bill and Sandy, welcome to the Physio Discussed podcast. It's great to have you on. We're going to be talking about pelvic pain today, which is a big subject, but it's great to have you on.
Very happy to be here.
Thanks for having us.
Fun to talk about.
I think we'll make it fun. I certainly think it's going to be interesting, and I'm sure the listeners are keen to gather some thoughts of yours and also really help improve their treatment and understanding, I think. And we're going to kick straight off in a minute about how do we understand the drivers of pelvic pain, and something that we need to think about what's driving this pain, and how well do we understand that. Bill, should we get started with yourself on that one there?
Sure. Well, I'm not sure we understand it hugely well. We've got some ideas around it for sure. Again, the science is sparse, I would say. But I think, if you want to kind of put it into some broad headlines or broad titles, you're looking at maybe muscle dysfunction in some way. You're looking at nerve irritation, sensitization. And you're looking at biomechanics and lifestyle factors, which includes obviously it's a big biopsychosocial arena, because I think it's as a condition, it's difficult to diagnose. It's difficult to get a diagnosis. It's then difficult to get someone that maybe understands what physically can be done to the pelvic floor to help change the symptoms. And I think both Sandy and I are coming from a kind of a background of a very holistic kind of centered background of looking at all the different components that play into it. So, and I think it's very different for different people. It can depend on like your are you an anxious person? Do you have a propensity for that? Are you able to relax? Do you live a life that's full on with a job and a family and lots of demands placed on you, and you trying to cope with pelvic pain amongst all of that? So, but I think that, from a what can we do about it point of view, it's definitely muscle, nerve, and then kind of lifestyle and psychological factors.
Brilliant.
Just
Nice.
everything.
Yes, exactly. I was thinking the same thing, Sandy. Any additions to, well, you can't addition to that, but anything else you want to add to that, Sandy?
Oh, one thing that what Bill said about the not just lifestyle factors, but how you go about in your life, um, totally unscientific. But I think that the people that I have treated over the years that have persistent pelvic pain are just smart people. Like, is there a correlation to how overthinking do? It's like the we play to our strengths, and we're people that are really good. I had a patient once that when I first was doing biofeedback ages ago, I did the test on her, and she was like, "Hey, I scored really well," and I'm like, "Well, technically, if you're walking around with really tight muscles all the time, that's not really good. Be like walking around with your fist clenched." But she's like, "Can I take this to my office? Because we talk about, happened to be a lawyer, that the more tight-assed you were, the better you were." And she goes, "I think I should get a raise." And I've thought about her periodically. It's like a very intelligent person, was trying all the things she knew to help herself, but it was getting worse with the effort. And I think that's something that in how we go about our lifestyles is, do we remember to let go?
Mm.
And can you relax? Maybe, but maybe you just don't, and you forgot what that feels like. And not to oversimplify, but what happens if the nerves just are squeezed all the time and you learn how to stop doing that?
It's that
But
habitual tension almost.
drive, not as a anxious,
And I think as well,
maybe,
Sandy,
but also as a, I'm gonna go get these things.
Mm.
we don't have much awareness or connection of our pelvic floor. And so the idea that it might be tight is kind of almost a new idea to people. They think, well, the number of times I see patients that after I've seen them a couple of times, they went, do you know, I really get this idea that I'm walking around all the time really tense in my pelvic floor. And that strategy you taught me to let go, I'm just blown away by the fact that I let this go and there's this massive release in my pelvic floor because there's also a kind of idea that your pelvic floor should stay tight all the time.
Mm.
So wee yourself or so you don't poo yourself or so you walk around with the whole thing tense. Whereas in actual fact, we don't need that much tension in the muscles to stop like leakage or a leakage of urine or feces. So it's kind of I always say to my patients that especially the guys, because guys are often told that they don't have a pelvic floor, in various. I mean, it's kind of astounding, really, but and they have no connection with it, and everything that happens in their pelvic floor is a gift from the gods. It's bestowed on them from on high. It arrives, it works, you use it, it leaves. When it goes away, you don't consider it until you need it again. So if you have to start consciously trying to connect with it, there's a lot of perplexity. There's a lot of looks on faces like, you want me to do what? And yeah, so I think definitely that we need to. It's the very, very first thing you do with patients is education, is try to say to them, look, you have this pelvic floor, it's there. That thing you said about walking around with your fists clenched is such a good meta for them to understand because I'll say, if they say, well, I still don't understand why is my pelvic floor doing this? I said, well, if you walked around all day with your fist clenched, I said, do it now for 2 minutes. Now squeeze them as hard as you possibly can. Now sit there and talk to me and tell me how you feel after 2 minutes. You're going to want to let go. You're not going to want to have those muscles so tight. And so they kind of think, oh, okay. So if you see this kind of realization during the first session that, oh, okay, maybe there's something here. Maybe I can do something about this. Maybe I can connect to this because they're often probably you're exactly in the same boat as me, Sandy. You're kind of like a tertiary referrer. So often the people that come to you have tried lots of different things. Frequently, the very last thing they've been told is that there's nothing that can be done for them, and they're going to have to learn to live with it. And if you're quite young, that's quite a challenging thing to hear. To think that this really, really disabling, painful condition is something that is not going to be treatable. And the doctor or whoever you've seen, the clinician, has not given you something tangible that can change it. So
They've
yeah,
been told you just to learn to cope with it, and you're an
yeah,
18-year-old guy who's
that's
like, this is my life now.
and if they're told that, they don't want to live with that. And that's the huge big sequelae of this is that there's a lot of people, it can really affect them psychologically, and that's where the psychological component comes in, I think.
It is not, none of us can do this by ourselves. It is a team effort with, I
100%.
think, pain in general, but pelvic health in particular. Um, I, for the previous part of treating in my professional career, very much a tertiary, like they've tried everyone before they've come to see me, and I just hope not to be one more failed attempt. But I have the absolute luxury of working with acute care providers. So I'm seeing people that have horrible pelvic pain, and you ask how long it started, and they say last Tuesday. And I'm just like, oh, this this is such a valuable opportunity to what if we can really treat it in acute populations and have it not get persistent.
Yeah.
Um,
And
I
I think that is possible. I think actually I see quite a lot of the longer I've been in practice, which especially in pelvic pain, 40 years in physio, 20 odd years in pelvic pain, people come to see me sooner, and absolutely treating them sooner is better. They improve quicker, they do better, they're able to take their own management strategies on and really work hard at them and really turn the control around so that their condition isn't controlling them and they're controlling it. So
That's so
100%.
important though, because then the self-efficacy gets high instead of
100%.
squashed.
I think it's interesting talking about pain because I often say to my patients, in fact, I think I'm almost always say to them, that you're not, I can't treat your pain. I said, because it's too hard. Pain's too hard a thing to treat, but actually I can definitely help you feel less hopeless, and I can help you feel less miserable. And if we can reduce your misery and reduce your hopelessness, your self-efficacy, your self-worth, your whole sense of who you are, really, really improves. I think recently I had a physiotherapist come to see me who had pelvic pain, and we had a big long chat, and at the very end of the interview, he said something really interesting to me, and it kind of harks back a little bit to what you were saying about pelvic pain and how it's different to other pains, Sandra. He said to me that his pelvic pain somehow had got to the essence of who he was, the essence of his being, and the very soul of him. He said he'd had sore shoulders, sore knees, sore backs. He'd had the whole lot, but his pelvic pain had really absolutely like really taken him down, like really, really knocked him off his perch. And I think that is the thing about pelvic pain that's so different to other pain conditions.
I talk about Melissa Farmer a lot because I admire her greatly. She is a psychologist, researcher, does basic science, and she's the one that was the author of the mouse vulva study, where she actually went and irritated little mouse vulva to find out what happens um, to acute vulvar pain in mouse and mice and whether they'd still have sex. And it's a fabulous study, just conceptually, and also, how do you do that? But one thing that she did at a presentation, I think it was the first World Congress on Abdominal and Pelvic Pain, that has stuck with me since, is talking about how in the hierarchy of needs, peeing, pooping, and sex are part of that base level, and they're all supposed to be pleasurable. Like none of those are supposed to hurt. There should be a feeling of relief after a good poo where you finally get to empty your bladder, and certainly sex should always be pleasurable. Um, the loss of that has a multi-layer hit because you not only are now having a negative experience with functions that have to happen, um, and all of the consequence of that, that you have lost some pretty important pleasures that help to regulate us, that help to keep us healthy, and taken those and twisted them into something negative. And just the power of that, I sort of sat there in the conference like, whoa, yeah, that would be that essence of who you are, and the very
Mhm.
basis of our needs gets disrupted. Everything above that is affected.
Yeah, I think that's true. And I think we're kind of predictive machines, the way our minds work. If you look at Andy Clark's work looking at AI and on the boundaries of how our brains really predict pain, and how pain, the predictive model of pain really
Mm.
starts to really play in with you've got kind of things in your brain like neurotags, and the neurotag for bladder, the bladder can be really close to the neurotag in your brain for, or be part of that neurotag rather, for peeing. And so if you're, and also, so it's all tied in with urinary function, your prediction that when you get this feeling that that's going to cause bladder symptoms, it's going to make you want to pee. So you get, and it, there's a huge stigma around peeing yourself and leakage and that whole issue. That I remember last year at ICS Toronto, or the year before, there was a guy who did a talk, a fantastic talk, with the idea that urinary incontinence was a social construct, and that in fact, if you lived in a country where you could just pee at will, then you could never be incontinent because you could just go pee behind a lamppost and it would be absolutely acceptable. And we have a little bit, we have it close, and we have it in France. They have pissoirs in the street. You can see the legs and you can see the shoulders. You just can't see the bit in the middle. But it's kind of
Germany, you just got to
bad.
be careful walking by a bridge because there were an awful lot of people when I
Yeah,
lived there that were
I
just
know.
peeing off the bridge. You're like,
Yeah, exactly,
okay.
exactly. So, but it's kind of interesting how that whole thing ties in with shame and how people feel about themselves. And there's a whole bunch of how you feel about your body, and how you almost feel like your body's lets you down, and it's a big disappointment. And also, like you say, if you're 18, and a lot of the patients I see are probably 25 and under, so they're young people, they're dating, they want to have sex, they don't want to be peeing themselves, they don't want to smell of pee, they don't want to be in pain. And pain gets rid of your your libido, doesn't make you feel you want to have sex, makes you wonder, especially if you've got complicated things like pain with erections or pain with ejaculation. That can be a really off-putting thing when it comes to you having sexual relations, and it stops you dating, it stops your whole life. Like that's not what you should be doing when you're 18. You should be meeting people, you should be exploring sex, you should be doing all of the things that 18-year-olds want to do, and it's that inability to do them, I think, really, really, really drags people down.
Yeah. And robs them of what should be fun and pleasure. And my
Yeah,
apologies for the cats.
yeah. 100%.
Absolutely. So I think we've really, really exposed how important this area is, and Bill, you sort of likened to the patient that you saw that said it's really getting to the essence of their being, and how important that is. So in terms of the treatment that we have, so the ability to help these people, where would you say that the research is at the moment? And from a clinical point of view, how confident are we that we can relieve and eliminate the pain? I mean, we talked about that, Bill, already, but improve the symptoms for these people.
Well, I wanted to start with one paper, okay, from ICS Madrid, which was by, and I'm going to read it because I can never remember her name. Starzek Prosperio is her first name, and it's a paper entitled "Effectiveness of Non-Pharmacological Conservative Therapies for Chronic Pelvic Pain in Women," and it's a systematic review. Level 1A evidence, and it basically, which is fantastic for us, because to be honest, we have level 1A evidence for the treatment of incontinence. So we know that physiotherapy to if you're leaking really is really good. It works well. Okay. But this paper was great because it basically looked at multimodal physiotherapy. So it looked at different things like hands-on therapy, exercise therapy, breathing. It looked at some psychological input. And what it found was that it was really effective in women with CPP or chronic pelvic pain syndrome. With a high certainty of evidence. So the way they did the study, they were really rigorous in how they looked at the papers that they chose to include. And they really, it came up to say that this should be a first line approach when we're coming to treat conservative treatment options, and not to go down a surgical route, perhaps tie in with pharmacological route, but maybe that makes it a bit more effective. But this paper said that physiotherapy should be almost like a first stop. And I think that was the first really decent paper. There's some other work by Marden, and I think that was the year before, or 2022, and that
Mhm.
looked at treatment recommendations, and they were looking at kind of surgery and the whole medical kind of intervention, and found that it wasn't very successful really. But this paper by Marjotta is fantastic, and I think it really is the first time that we've got a basis to start from, I think.
Yes. I also like Katie Vinson's work on endometriosis and encouraging physical therapy as a first line treatment for endometrial pain as well. Um, There is one of, and full disclaimer, it's a friend of mine, of Lori Forner out of Australia, just finished her PhD, and she was looking at prolapse, the likelihood, sorry, Lori, of prolapse if you were lifting heavy for women, which isn't pain, but there's so many people that have that sense of fragility that I've been using her research around. Look, you can lift heavy, and it's not likely that you will increase or give you any prolapse, whether you've had children or not, to encourage people that have pain. It's like you're not fragile. It's a really strong, really protective bit of you. Nothing will fall out or fall off. We know that it's safe, despite all of the aunties that have told you, oh, you hurt, you should never run, or you hurt, don't sit, which is just daft. Like, how do you go through your life not sitting? And
Totally.
although there's some very not good information out there, we're starting to get some good evidence to say, here's a direction to go instead. Do we need more? Yes. Do we need the
We need
clinical
way
practice
more.
guideline to get finished?
Mhm.
Yes. Do we need Jilly Bond to finish her work on sensory integration and what we can do with that? Yes, but it's so much better than even 5 years ago.
Yeah, definitely we're getting there. I think the loading thing is really interesting because from a kind of a layperson's point of view, if you've got pelvic pain and you go on to patient support groups, it often says don't lift weights, don't lift heavy, don't go to the gym, don't exercise, don't squeeze your muscles because that's going to cause all sorts of problems. But you have to move. I mean, people are, if you think of, you even think of, I think the best example is a young mother goes to the doctor and with a prolapse is really interesting. It's not pain, but it's a dysfunction. And the doctor says, whatever you do, don't lift anything over 4 or 5 kilos. As she stands up and lifts up her 15-kilogram baby, her 20-kilogram bag of nappies, and her buggy, and says, "Okay, I'll do that." And I think so. We have this kind of a lot of mythical support and information out there. And I find that I totally agree with Sandy in that there's a fear, they have fear avoidance behavior. They come to the clinic, they've stopped exercising, they've stopped. I often say that the treatment of these guys is all about one thing, and it's all about movement. And they've stopped. Maybe I had a triathlete once who's a really good example of this, who stopped cycling because of his pelvic pain and it didn't get any better. So he stopped running because of his pelvic pain and it didn't get any better. And then he stopped, then he kept swimming, but that didn't get any better. And he was a high level, he was a master's level triathlete. So he then decided to have a standing desk at work because he didn't like sitting and it didn't get any better. And he was doing different things, but nothing really improved. And by the time he saw me, he'd stopped leaving the house. He was lying on his couch to work. And then by the time I think maybe after I saw him, he wasn't even working. So he'd gone from this guy, he was training 7 times a week to somebody that just was not moving. And it was really interesting because you kind of think that's quite a complex scenario. But actually, my whole approach with that was how do I get him moving again? What did I do to get him moving? Because he's so far away from moving in any way, shape, or form. And it's about loading tissue. And we're understanding more and more about tissue load and training load and how we can apply that to pelvic floor function. And I think, like Sandy says, there's been some really interesting studies, especially around the perinatal, postnatal period, looking at the effect of heavy lifting on women and babies. And there's no negative effects. The effects are all really positive. In fact, they reduce all of the complications you would expect with pregnancies and deliveries. And I think that it would be great to have some research looking at strength and conditioning and pelvic pain. Because Sandy's laughing because she knows that's what I'm going to go and look at. So I think that for me, I love to get tissue loaded. I think tissue becomes healthy when you load it. That's what it's designed to do. And the more we can load it, and all of the other positive psychological effects of building resilience and strength and reducing the sense of fragility. And these guys often, guys especially, think they're broken. They think they're done. And so we need to give them that sense of confidence back. We need to and I think Sandy said something at the beginning as well, like walking the journey with them, like we're side by side with them because we have to take them on it. They need the confidence to go there and to do it.
Scary. People stop doing things not because, well, sometimes because they're told to, but also because it hurts. It's like, and I say do squats, and they're like, yeah, it hurts, and I'm like, do squats anyway. But we modify it so
Of
that that
course.
is a minimal amount. It's like that I
Mhm.
think completely made up rule of no, don't increase your pain more than +2. Like I've never
Mhm.
been able to find a citation for that. So if you know one, Bill, let me know.
Funnily enough, I was talking to someone about this on the weekend about, who decides, like, let 2 out of 10. And actually, visual analog scale, they can be useful for me, but does the patient care about them? No. Does the patient often get a little bit upset when you ask them to give them a score out of 10? Because how can you take this really complicated experience that you're going through? How can you take your nociceptive feeling and say it's 2 out of 10, it's 5 out of
Well,
10? Because it's like
yeah,
it
you have to use
totally
many,
is
many scales.
contextual. It's really contextual, isn't it? I mean, I remember having a rugby player who played for the national rugby team come to see me because he had hurt his leg during the game. He had played the whole match, and I said, "Look, I need to send you for an X-ray. I think you might have fractured your fibula." No, no, I can't have. It wasn't that sore. So he went and had his X-ray, and he had fractured his fibula. But he'd played 90 minutes with a broken bone. And then as soon as the X-ray came back, he said, "Oh yeah, I'm on crutches now because I can't walk." So, contextual factors we understand have this massive role to play. But I think, yeah, 2 out of 10, I kind of find it useful. I like it to see if my treatments are working, but that's about all. I don't really like it to say to the patient, "Look, your 2 out of 10 might be my 6 out of 10." And I
Very much.
work a lot with dancers, and dancers, my 6 out of 10 is their 1 out of 10. They have no sense of pain. Their concept of pain, they think they dance through pain, and there's lots of scientific evidence out there that say the dancers don't have a different pain perception completely to the whole of the population.
What's the meaning? What does the pain mean? I just
100%. Yeah.
just did an old person injury and was hurt my ankle the other day at work, showing people doing progressive box jumps because I missed my landing, and I just like shrugged
You
it off,
did.
sprained my ankles a million times, and it was like whatever, it's just pain, and like okay, a little warped, but moving through it because I know that the tissues will heal faster if I use them. That knowledge
Hmm.
outweighs the it hurts to do this because I don't think I'm hurting something.
Yeah.
Um, I think this is a healthy thing, and if it's a little aggravated, that's fine. I can calm it down and do it again. I'm safe. I'm good to go. But that is a knowledge that I have from years and PT
Hmm.
school and research and classes. And I, look at relatives and friends that are like, "Oh, I heard I shouldn't do it. It'll make it worse." And you do have to know, like, when does pushing it make it worse, and
Hmm.
when does pushing it make it better? And for that's true for ankles, which you can see and compare to your other side pretty easily. It's really also true for pelvic structures, but we can't see them. And even if we looked at them, they're not, if that's not visually meaningful information. So you're trying to change function that is normally unconscious by consciously paying attention to it, but not too much because that can increase the symptoms, and you don't have a norm to base it on. So that's tricky.
It's very
Um,
tricky. Yeah, very tricky.
it is possible to go to the question to can it get better? Yes, pain gets better. Do we have a great way to know what the most efficient way to get someone from where they are to where they want to go? No, but we're better than we were. I wouldn't call it efficient yet. There's still a lot of trial and error.
100%. I think with all of our pelvic pain patients, I mean, we all have our biases and we all regress to those. And
Hmm.
I think, because it's where you're comfortable, isn't it? It's where
Well,
I want to go to where I think I know how I'm going to help this patient. But I always think every patient I have is, and I heard Ebony Rio from Australia say this, so I was really, she said it before me, but I've thought it and said it for a while, so I don't feel I'm stealing it for her, but I remember hearing her saying it and think, damn, I've not been able to say that before now. But I think every patient we have is like an N=1 case study, and we're collecting data, and we collect the data, and then we have to create a hypothesis, and then we maybe even try to have to reject that hypothesis, and if we can't, we have to accept it. And if we have to accept it, then we know we've minimized our bias to a degree because we've followed some kind of scientific rationale or algorithm to get to where we are. Like you said, I don't think there's always a straightforward answer. Every single patient is really unique. There's kind of trends and things that we do. Um, but I think physiotherapy is one of those interesting. Well, I think every every single job, every single vocation, every single kind of profession has this. I used to always say that we're a bit like whatever's trendy, like maybe non-relaxing pelvic floor muscle. You write, it's like primary 7 kids playing soccer. You write it on the ball and you kick it up the park, and everybody runs after it. And hey, they pick up and they go, "Hey, it's non-relaxing pelvic floor this month." And of course, it's way more complex than that. You know,
It's grand.
yeah, it's a little bit of this and a little bit of that, and sometimes what happens when you get a patient that comes in with non-relaxing pelvic with normal pelvic floor tone and they're in agony, and you're thinking, okay, this is throwing me for a bit, and so you have to step back and you have to try to analyze the information you've got in front of you, and again, if you have a more kind of pragmatic approach to it, when it's about when the diagnosis, I think that thing about there's not always damaged tissue in these patients. There's not always damage. There's not always injury. That whole concept that there could be nociceptive output, which is causing a pain experience without there being actual damage, or damage that perhaps maybe if it has been there because of trauma or infection has healed, but the pain has stayed. And then what do we do about that? Because do you know, patients, you probably feel this, I think, Sandy, as well, because I think maybe we spoke about this, is like pelvic floor patients have often been told this is all in their head. And I think one of the things we know about modern science of pain is that whatever, if a patient says they're in pain, they're in pain, and that's their experience. That's their. We have to believe that, because if you don't believe it, you might as well send them to see someone else. Because if you're going to disbelieve them from the get-go, and they often feel like they have been a bit disbelieved when they don't leave with a bag of medication or a prescription for something from the last consultation they had. They feel really that they've been cast adrift. They feel that there's nowhere to go. And I think frequently, if you treat pelvic pain patients, the thing that you hear after the first initial appointment is, I feel that you're the first person that's listened to me, and I feel it's the first time I've been heard. And I always try to do three different things with my patients. Guys, we're especially because I see 95% men. We're simple beings. We like it straightforward. We don't like anything too complicated. And I'll say to them, look, so what's going to happen today is we're going to try and find out what's wrong with you and give it a name. That's the first thing. The second thing is we're going to try and figure out what we're going to do to try and help you on your journey to recovery. And then the third thing is we're going to try and figure out how long that's going to take. And I'll say, and I know that's putting my head on the slab. I said, but I like to do it because actually they leave thinking, all right, okay, so this guy, he listened to me. He seemed to have some understanding of what I was going on about. He also has some kind of logical plan that I'm going to follow. And he's using my symptoms to measure whether or not that's going to be effective. And
And
so,
you told them that you expect it to get better.
yeah, yeah,
And the
100%.
question,
Yeah,
it
100%.
isn't, the question isn't, can it get better? The question is,
Yeah.
how long will it take to get
Yeah, yeah,
better?
100%. I say to them, look, I've been doing this for long enough. I've seen thousands of patients, right? You can get better from this. I know you can. And actually, if you go back to some of the early literature on pelvic pain, it was written about as a self-limiting condition. So it would often go away. And sometimes when you speak to guys who've had it maybe for 25 years, they say, oh, I was okay for 5 years. Then it came back. Then I was okay for 10 years. Then it came back. So I think we know that it can definitely go away. And I think with physio and movement and loading, and maybe some specific work on tissue when it's required, then it can be a really effective thing that we do.
And one of the things I love about our profession that often is that when we do our jobs right, we help people not need us anymore.
Yeah,
And we're there for consultations, but it's not, you have to come see me once a week for the rest of your life kind of thing.
yeah.
But look, I'm here in your corner, but I'm going to give you the tools to take care of yourself when this flares and manage it.
It's funny, isn't it, when you treat people with pelvic pain and they kind of leech on, they clutch onto you and they don't want to let go.
It's a little
And
lifesaver.
they're like, it's like you're like a lifesaver. And I frequently say to them, I said, so I'm going to ask you to do something today. I want to do a little bit of visualization with you. I said, I want you to think about the yoke that you have on your shoulders, your pelvic pain yoke. I want you to take it off, and I want you to leave it in the corner. And I want you to leave without it today. And I'll take care of it for you. I said, don't worry, I'm not going to chuck it out. I'm going to hold on to it because people identify with the whole experience they've had. So I'm asking them to leave some of themselves behind with this idea that you deserve a little bit of support with this. I almost encourage them to become a little bit resilient on me or reliant on me rather in the very first few sessions so that they feel super supported so that they can understand really, really quickly that they don't actually need me that much. I'm their check-in. They can come back and see me, but it's kind of like, I believe you, you're heard, this is what you've got, it will get better. Let's see if we can figure out a plan for you, a journey for you to travel down to try and improve it.
And really
And
pointing out that their recovery path is unlikely to be the same as the person's recovery path
yeah,
they're reading online.
yeah,
Or
yeah,
if they read online that someone tried what they're currently doing and it didn't
yeah,
help them,
yeah,
that's
yeah,
actually
100%.
normal too.
Yeah.
Um,
It's
and
like
the
the idea
reporting
of,
bias of the people who got better aren't usually online talking about it.
the number of times I'll say to guys, look, with this, once you're better, you don't want to be in a patient support group. You don't want to like you hightail it out of there. You run down the street and go back and have sex and live your life and go and do everything that you've not been able to do. And the last thing you want to do is talk about it. You want to just go and just go and live, just go and be yourself. So I totally agree with that for sure, for sure.
And it, I like a little point on bias is just because you're biased doesn't mean you're wrong. It,
No, no, no.
it's be very,
I
very right.
sometimes I love my biases. I love them.
Cozy. They're comfortable and cozy.
Yeah, of course they are.
I have on pain scales, I have there's someone up in Canada, it's called Bibby Pins. I get nothing for recommending that, but I have a bunch of her pins on my wall in the treatment room. And the one is a pain scale, it's 0 to 10, but there's an exhaustion, an anxiety,
Hmm.
uh, there's a hunger one that I don't have up. There's a couple other ones that are a little off color, and the clinic requested that I not put them up. There's an existential dread one, and it's just by the door in my treatment room, so the
Existential.
people who've noticed it can come in and do their little, yeah, my pain's a 3, but my anxiety's up here at a
Hmm.
9.
Hmm. Hmm.
Or I've noticed that when my anxiety goes up, my pain goes up. Or if I'm not sleeping, my pain goes up. And you start to see the equalizer effect. So it's not really just the pain scale. It's
And I think I'm going to jump in a little bit about anxiety because anxiety is my kind of, I find it a little bit triggering because anxiety is one of those things where we can gaslight our patients, I think, because we can say, oh, you're just anxious.
yes,
And that because that anxiety is your thing, therefore that's not my responsibility. And actually, your anxiety is stopping my very, very fabulous treatment from working. So I would like you, and actually, it's really funny, isn't it? Because if someone shouts to you, relax, what happens? You clench your sphincter. You don't relax your sphincter. You go,
relax now,
what? Because it's like,
relax fast.
what's going on? What's happening? What's happening? So never, never in the history of someone being told or shouted at to relax has that ever happened. So, and I say to my guys, anxiety is an interesting thing because again, it's a social construct. It might be and it's maybe a medical construct. I said, but it's basically fight, flight, or freeze. It's basically physiology. It's basically our autonomic nervous system making us feel we're dumping adrenaline and cortisol into our system, and we feel like shit. And that basically is anxiety. Now, that's really important because the reason for anxiety, the reason for fight, flight, or freeze is so that you survive. So it can't be nuanced. It's either on or off. Because if you go, oh, is that dead? Is that a danger? Dead. Every time you stop and think about it, you're a goner. So you have to respond in that way. But obviously, pelvic pain isn't going to kill you, we hope. And so the deal is I get my guys. I've been doing it for a wee while now, and I'll say to them, "Do you know what? What happens if somebody comes up to you?" And actually, I stole this really from Jilly Bond, and then expanded it a little bit. But it's brilliant, really. And I'll say, so the first thing that happens if you're a zebra at the watering hole, and a tiger comes to get you, and I know that's wrong because they're not from the same continent, but I like the analogy, so I'm sticking to it. So basically, the tiger comes along and attacks you. The first thing you do if you're a zebra is you go back up on your hoofs and you try to fight the tiger off. And you do that for, I don't know, 30 seconds, 40 seconds until you're exhausted. And then what do you do? Then you take off. And then if you run fast enough, so the other thing about pelvic floor function as well, which I'll say here, is if you're able to defecate quickly and urinate quickly, you can jettison 10 kilos of poo and pee. So you're 10 kilograms lighter than the guy beside you who's still having to run with the 10 kilos in his hands. So you get to escape and hide behind the rock. And when you hide behind the rock, what do? You freeze. and you breathe and you try to breathe really slowly because you try to bring back you've burnt off your adrenaline cortisol and now you want to increase your parasympathetic activity to calm yourself down. So I get them to do things like, I say the first thing is get into fight stance and start boxing for your life. Box as hard as you possibly can. Then once you've done that for 90 seconds and you're just absolutely exhausted, get running. Because now the fight didn't work, you've got to get out the way. And then once you've done that, go and hide behind a rock and breathe and so work on that physiology of the anxiety to bring it down a bit. And it works for all sorts of pain, but it works especially well for pelvic girdle pain patients and pelvic floor pain patients. And I think I'll say to them, take some of those things, take some of those the part of your journey that you really didn't like, which are the little triggers that give you anxiety, and put them in front of you. I says and punch them out the way, punch them as hard as you can, run away from them as hard as you can, and then hide from them as hard as you can. And actually, a lot of the guys, it's just one of the little strategies that I really like for my pelvic pain patients to use when we're talking about anxiety, and to say to them, you know what, anxiety is not this thing that you can't manage or control. And I mean, there's lots of psychological things to do, but as a physio, I want to be moving my patients. So of course, I go and try and find something that's about exercise, loading, and move. So anyway,
Because we don't do like, if you get a cramp in your foot, you stand on it, you move.
yeah,
You don't lie
100%.
down, stick it on the back of the sofa and wait for it to go away. But
Or
people get
breathe,
a cramp
try
in
and
their
breathe.
ass and
Yeah,
they're
no, you
like, oh,
no.
don't sit. Here's your little
Can't breathe,
cushion.
you can't. So you jump out of bed, don't you? And if it's in the middle of the night, you don't stay under
You
the
need to
covers.
get,
"Oh, I think I have some cramp. I will breathe through that." No, you scream, jump out of bed, and your partner's going, "What are you doing? What's going on?"
yeah, and we gotta do the same thing with the pelvic floor is load it, like for real load it. And
Or real load it, yeah.
I
Absolutely.
love that. I put people in virtual reality. I have not, I'm gonna so totally steal that from you and Jilly about, okay, here we go. I have rocks outside the clinic. We could do this. So you were talking, I'm like, oh yeah, I can use that. But I put them in VR. Beat Saber is a fabulous thing. Put that on a level higher than you think you can do for
Mhm.
10 minutes. And they're moving in ways they've been protecting and all kinds of stuff's going on where they just don't, they're not thinking about it anymore because they're
Yeah.
trying to smash those boxes that are coming at their face really fast.
Yeah, absolutely.
Um,
Yeah, I think
and that
that
none of what we have talked about has been people lying on the table, breathing and doing pelvic muscle relaxation exercises.
I think, sometimes there's a big spectrum, isn't there? If you get someone maybe might have a real fear about moving. So you have to grade it for them. And it's like, but if I'm giving them I will say to them, I like breathing. I like nasal breathing. I
Mhm.
like I like using. I'll get them to use like nasal clips to open up their airways so they can breathe better. I'll get them to do breathing and start and take the breathing into their workplace. Get them to do their breathing exercises sitting up at work, because that'll, if you can reduce your sympathetic nervous activity by nasal, slow, vagal breathing, that can be a really positive thing. And then it comes back into just about getting control. It's about being in control and feeling that you can manage. And you have a bunch of strategies to apply to your symptoms that you can control a bit.
Yeah,
And I think,
buffet of options because the one
yeah,
that worked yesterday won't
yeah,
necessarily work today.
100%.
And that's normal too.
100%. And that thing you used to say about, I love your little thing about like exercise snacks and pleasure snacks, and go out for a walk at lunch. Go and have that, go and have that coffee that you really, really enjoy. Like, because there's lots of kind of, don't eat this, don't eat that, don't drink that, don't do that. But actually there's not that much evidence regarding nutrition and irritation and food. Now, for some people, that's the thing, but for a lot of people, it isn't. And for
Right,
people
and the
that have
blanket don'ts, then you end up having stolen everything that makes a
every
person's
pleasurable
life
thing, yeah,
enjoyable.
sure. Yeah, 100%. Though everything you used to enjoy is gone. You limit yourself. It's like going on a diet. You just take all the pleasure. It's like,
Oh,
people
and that's
say,
just rude. So we have to find things that people can do that feel good
yeah,
for the kindness, the compassion, and practicality of it, but also for the treatment aspect of it, because
mhm,
doing things that bring you pleasure decrease the cortisol levels, increase dopamine, serotonin,
yeah,
oxytocin, get you
yeah,
in a less contracted state. It just changes the whole chemical output. So if we can tap into that for 2 to 3 minutes periodically through the
Yeah,
day.
totally.
Total bonus.
And I think as well, the whole thing, a lot of the stuff, sex is an activity of daily living, isn't it? And
Absolutely.
we come away from it, we stop doing it. And so what tends to happen with when you stop having sex is that you stop having intimacy. And when you stop having intimacy, that makes you feel really alone and sad and low mood. And so I encourage my patients to say, go back to your partner, say to them, this is where I am, get a foot rub, get a hand rub, get a head rub, have a cuddle. Take 10 minutes every day and say, okay, I need my pleasure snack now. We're going to cuddle together. Guys especially often don't look for intimacy when they're not looking for sex because they're slightly worried that if they go towards the intimacy, that might lead to sex. And they're not sure if it's going to be possible and they're not sure if it's going to not be sore. So therefore they kind of stand back a bit. And then again, there's this and then the whole issue with how your partner, how there's a gap between you. And oftentimes, the thing about pelvic pain patients is they actually look, or they can look quite well. They don't have a cast on their leg, they don't have a brace on. There's no face validity that there's anything wrong with you because it's hidden, it's embedded in your pelvis. And so sometimes, people are looking and say, "Oh, you look okay. What's wrong with you? You're young, you're healthy. Why are you here?" And so, and also they put on a brave face because they don't want people to know it, and that's exhausting. That can be really, really exhausting.
And I think leads to more tension and
Yeah,
more loss of the things that make you feel good. So just is the wrong road entirely. And
yeah,
you get further and further away the things that can help you recover.
yeah,
And as health providers, we need to we need to not be adding to that. Um,
yeah, for
so
sure.
helping people keep options and know that pain is weird and even pelvic pain. It has that extra level, but also just pain in general, and you can't rest it better after maybe that first initial bit where you're making sure that bones aren't actually broken and, this is, I am structurally sound, so I can load this. That part needs to happen, and then you need to grade that exposure. But that's where pelvic stuff becomes really interesting. So yes, intimacy, but it's like diving off a board. At some point, you can't just practice. You're going to have to do it.
Well,
And that's where it's like I've worked with gentlemen, especially of look, okay, you're structurally sound, you're fit for purpose for all these different pieces. Go have sex,
yeah.
but go have sex the weekend before your appointment, so that if you end up with a spasm or you something doesn't go the way you wanted to, I'm here for you. I can help you calm everything back down, and don't send pictures. It's like just do this.
Please, please
I'll
don't.
trust you.
I mean, I had a patient recently. He wanted to come see me. I hadn't seen him for a long time. He was doing really well, but he hadn't gone back to being sexually active because of the pain. And he phoned and said, "I think I need to come and see you." And he was being quite specific about what his issues were. And I said, "Mate, I think you just need to go out and find someone and have sex. I think you need to go date. I think you need to go find some people, go and live your life." I said, "Go do that, and then come back and tell me how it goes." So I didn't hear from him for a bit, and I thought, I wonder if I've given him the wrong advice. So I sent a text message going, just checking in, how you doing? He went, "Oh, great. I have a girlfriend. We're having sex. It's working well." I said, "Do you think you need to come and see me?" "No, I don't need to come and see you." And it's a bit like that jumping off the cliff. It's about it's not even about giving, it's about being validated about that decision is okay, because the last thing they want to do is do something that makes them worse because they've tried super hard. And I think I used to say to patients, I still do actually, the only thing that's worse than the pain that you have on the first day that you come to see me is if you have a flare during treatment and you suddenly think you've absolutely gone back to square one. I said, but you haven't. I said, you absolutely haven't. All your benefits, all the things that you've gained on the path are still there. You haven't lost them. And I think it's that idea about bridging the gap between pelvic health and whole body function. Like the pelvic health, the pelvis is not this area separate from the rest of the body. The penis is not this organ that is disconnected and doesn't connect to everything else. The vagina is not this thing. It's not an island separate from everything. Everything goes together, works together, and it's part of this larger system that's absolutely tied in with everything that we do, for sure.
That was a fabulous summary.
Very good.
Well,
Brilliant.
well done.
We've literally got less than a minute probably to go, both of you. It's been brilliant listening from my point of view. So I bet the listeners have been enjoying it as well. I'm going to get the listeners to be left with one thing now, and that is one thing that you individually, yourselves, would want someone with dealing with pelvic pain to know. Let's
Mine
start with
is
you, Sandy.
always pain can and does change, and there is help. So be courageous and seek help, and we can help you find people.
Brilliant. Bill?
Yeah, I would absolutely echo that. I think that pelvic pain, you're not stuck with it. There are things that you can do yourself. There are things that physical therapists can do, physiotherapists can do to get you in the right direction. It's not a life sentence. And have hope. Stay the course. Reach out, find someone that can help you, and I'm sure you'll get there.
Brilliant. Sandy, Bill, thank you so much for your time. It's been a real honor to have you both on the podcast, and thank you for giving up your time, morning and evening.
We
Thank you.
stand the whole day here.
That'd be good, couldn't we?
Take care, both of you. Thank you again.
Thank you. Bye bye.